All right, so let me welcome you to the session of maternal and child health regarding mHealth. We have a great panel. We have Dr. Alain Labrique. He's professor at Johns Hopkins Bloomberg School of Public Health and director of the JU Global mHealth Initiative. Then we have Dr. Pablo Duran. He is advisor for the Latin American Center for Perinatology club that depends on the Pan American Health Organization and WHO in Uruguay. And then we have Douglas Mbang. He's the founder and CEO of Public Health Innovations from Cameroon. So just a reminder, we will have the 3 presentations, and after we finish the presentations, we will have the questions from the audience. So please use the Q&A section to provide your questions. So now I ask Dr. Labrique to start with his presentation.
Thank you so much, Dr. Otero. And it's a pleasure to be here with such a fantastic audience. For those of you watching live or watching asynchronously, it's a pleasure to be part of this august group. And I'm excited today to share some of the latest work that's being done on the global stage with regards to digital health and opportunities for reproductive, maternal, newborn, and child and adolescent health, but also some exciting new findings from some of our work in Bangladesh, where we've been testing digital health interventions for frontline health workers to improve neonatal mortality. So as Dr. Otero mentioned, I'm professor at the Johns Hopkins Bloomberg School of Public Health, and I'm currently the Associate Chair for Research for the Department of International Health. I also direct the Global mHealth Initiative, initiative that brings faculty and students together from across the university around digital health. So with that, let me start with showing you this map that may be familiar to some of you, and that's the proportionate boundaries of the globe redrawn with respect to the countries that bear the greatest burden of maternal and newborn mortality. And you can see here how the concentration really afflicts countries in sub-Saharan Africa and South Asia. And for decades now, we've been trying to make inroads to reduce this burden, and we've been successful to some extent, but I think we do have some miles to go before we've achieved the goals that we have been hoping for. Now, what's interesting to note is as we look at another map of inflated boundaries, and that is the map of the mobile phone revolution that has begun in the early 2000s, we see how these very same places where the burden of mortality has been the greatest is where the opportunity to leverage mobile telephony is also significant. And so it would be a missed opportunity if we did not leverage this reality happening in the background of our public health efforts. Now, the reality is the world is connected now more than ever before. We have more mobile phone connections than we have human beings on this planet. And it has redefined the way we think about access to information, access to one another, access to health workers and the health system in countries which used to be low resourced and where populations were really out of reach for the most part for routine health services. And so it's redefined how we think about remote rural parts of the globe in terms of being able to engage with clients, being able to follow up for chronic disease management, and even for maternal and child health care. And so it's in this light that we ask ourselves. We used to use the word mHealth a lot. Now you'll hear that word supplanted by the word digital health, as we think about health systems that have been fortified using digital technologies. And I'll show you some of the latest recommendations that have emerged from evidence reviews at the World Health Organization. So back in 2014, which now seems in the digital space like a century ago, when we were still using analog lines and the cost of phones was still very expensive, we had already begun to do a review of how mHealth strategies could be used across the pregnancy and newborn continuum. And this paper was published in JAMA, but it showed how ranging from patient education to decision support tools and emergency referral, digital technologies had the potential to avert neonatal mortality and adverse outcomes in pregnant women. we were thrilled when Professor Tedros Ghebreyesus of the World Health Organization also supported this as one of his 3 reasons for optimism going into this new decade, where we have potentially the tools to accelerate our progress towards the goals we set as a global health community, but also to potentially increase oversight and decrease the lack of coverage of some of these interventions that we know can save lives and improve outcomes. In 2018, the World Health Assembly passed the first resolution that urged member states to consider digital health solutions where appropriate, integrating them into current health systems to strengthen the delivery of preventive and curative services in countries around the globe. This was followed shortly by work that we were helping the WHO develop, and that is a language, a common shared taxonomy or classification of ways in which digital tools could be used to improve health outcomes. And so it's this shared language that was published as part of the classification of digital health interventions that enables us to think about and communicate in a common language, spanning 4 main pillars: interventions that target clients or support clients, interventions which target or support healthcare providers, and interventions which support healthcare managers or supervisors of health systems. The 4th pillar is one that looks at digital technologies and supporting data services, that is to say, the synthesis and storage and aggregation of data and visualization of health system performance to understand whether the resources that we're putting into these health systems are having the impact that we hope they are. So in 2019, I was very privileged to be part of the first WHO guidelines for digital health, recommending digital interventions for health system strengthening. Now, this was a more than 3-year journey to get to this endpoint with exhaustive and extensive syntheses and literature reviews to digest and distill which aspects of digital health interventions had adequate evidence to make recommendations to countries and to implementing agencies. And so you can see here the range of recommendations that emerged from the World Health Organization's guidelines development group. And this is available online for access. Now, recently, just as the pandemic was beginning, we also were working on a landscaping of digital technologies for child and adolescent health, looking at everything from the way in which we incentivize health workers to apps that can be used by frontline health workers to better conduct things like IMCI, the integrated management of childhood illnesses, to reduce adverse outcomes. Now, we mapped these innovations and opportunities across the early childhood continuum, from cross-cutting interventions that span infancy to adolescence, but also looking at interventions that were specific perhaps to one of the areas of this continuum. In terms of cross-cutting opportunities, we identified telemedicine, decision support systems, and targeted client communication as key ways in which we could address some of the bottlenecks or pain points being experienced in the health system across these various pillars of that continuum. But in infancy, there were a few strategies that we saw growing evidence or strong suggestive evidence that these technologies were making a difference. So going from birth registration using technological or digital systems through the longitudinal tracking, such as immunization, growth, and nutrition of children as they went through these early phases of life, care coordination for severely ill kids, and the use of wearable biosensors, as you see pictured here at right, the Bempu Temp Watch, allowing workers and mothers to monitor child's temperature to ensure children are adequately referred when they experience hyper or hypothermia. Moving on to childhood, we now look at the advent of systems like longitudinal tracking. Are the children receiving immunizations as appropriate? Are they growing as appropriate? Are they receiving adequate nutrition if that growth is inadequate? point of care diagnostic devices continue to be useful, as well as decision support systems, but we also start to see the emergence of early childhood development applications that can not just look at the physical growth of children, but now start to explore the cognitive growth of children. We also see the emergence of on-demand services such as telemedicine and hotlines, where parents can call in with concerns about their children and be connected to a physician or a health service provider in a rapid, timely way, providing advice if needed, but also coordinating referrals if also useful. Once you emerge into adolescence, we start to see the opportunity for more sophisticated technologies that are increasingly taking the stage, as we've seen in this era of COVID-19, such as the use of apps to engage with patients or clients, chatbots, automated human-like interactive messaging that can assess the state of mental health, but also start to explore things as adolescents get into their early reproductive ages, sexual and reproductive decision-making, using these easier technologies that may circumvent some of the more challenging norms and cultural stigma around discussing these topics with family members or community members. You can see here in the picture a Butterfly IQ mobile ultrasound. That's a technology that's made considerable progress in recent years, bringing the power of ultrasonography to the point of care, wherever the patient may be, in a rural clinic or even at the domicile. Now, I want to switch tracks a little bit to travel with you to rural Bangladesh. And this is the country where I was born and raised. It's a country where I have been doing research now for more than 20 years, testing interventions to improve maternal and newborn survival. In a research site known as Jivita, since 2001, we've been conducting massive randomized controlled trials to measure the efficacy or effectiveness of interventions aimed at improving maternal and newborn health. We have over 850 staff, and to date, we've followed more than 150,000 participant pregnant women in these randomized trials, working very closely with researchers on the ground from Bangladeshi institutions, as well as a large staff of trained local providers. Now, very early in this mobile phone revolution, we began to see that rural families, in the absence of any formal mHealth or digital health program, were using mobile phones during severe pregnancy crises. And you can see here in the chart, for a range of various purposes. About half of women who experienced a severe obstetric emergency used a phone back in 2007, more than 13 years ago, to make a call during that crisis event. But the question persisted: how do we translate what's happening in the ecosystem into formal health interventions? Because the challenge of averting neonatal mortality is to be at the right place at the right time. In this critical window of the first 36 to 48 hours of life, when neonates are at the greatest risk. And you see here this famous paper from Joy Lawn and her colleagues showing how most of the deaths take place in that first week of life. So we tested a mobile health intervention to see whether women would inform us when they were going into labor, so that we could dispatch skilled clinical care to the home at the time of their going into labor. And we were able to show that 90% of the births were then attended by trained professionals thanks to this mobile phone system. So we went further to develop this into a formal digital health intervention ecosystem known as mCare, which began with the digital census and enumeration of the population, pregnancy surveillance using mobile phones to detect incident pregnancies, antenatal care reminders being sent to the clients, and then the ability of clients to request for help when they were experiencing a crisis. All of this has now emerged into the software platform known as OpenSRP, which was just determined to be a global good by the Digital Square initiative. In the pilot study, we showed that the mCare strategy, which combined a demand side and a supply side digital health intervention, a tablet in the hands of the community health worker, and text message reminders going to the families, it tripled antenatal care rates and doubled postnatal care rates in this pilot study. We also saw the early signs of potential impacts on neonatal mortality, which gave us the courage to launch a much larger randomized controlled trial that has taken us the better part of the last 5 years to refine, implement, train, and measure in communities across northern Bangladesh. So over these 5 years, we've consented and screened 125,000 women of reproductive age and enrolled roughly 16,000 pregnancies as part of this RCT. And as you know, there are few RCTs of this magnitude of a digital health intervention. So I really wanted to take the opportunity to share with you some of the exciting emerging findings from this RCT at this august gathering. What we found was quite astonishing. 93% of the families enrolled in rural Bangladesh, in a population representative of the greater Gangetic floodplain, owned a household phone. As we looked at the intent to treat analysis, so this is not the per protocol analysis, which would show certainly much higher impacts. This is the intent to treat, whether or not the health workers use their tablets as was intended. We looked at whether the cluster randomization showed an impact. What we found was no significant reduction in neonatal mortality measured independently. But when we looked at perinatal mortality, which is the window of time usually just before delivery and into the first few days of life, we were able to measure a 16% relative risk reduction in the risk of perinatal mortality attributed to this demand and supply side digital health intervention. We saw a 20% reduction in stillbirths, which often is a benefit that we see with improved antenatal care. And this has given us a lot of enthusiasm about the potential for digital health to really have an impact, not just on strengthening processes, but on actually impacting health outcome. We're also working in places like Uganda and Rwanda with some exciting groups in our School of Engineering to measure whether we can task shift some of these critical detection windows away from the health workers, who we know are few and far between when it comes to domiciliary visits in that early childhood and early neonatal period. And so what if we could empower mothers with the technology necessary to assess whether their child was breathing rapidly or experiencing a spike in fever or even hypothermia, signs that we know are indicative of early neonatal distress. So our engineering students created and field tested, and now they're in the course of doing a trial of this technology called NEMO, the neonatal monitor. That is a simple technology that is able to be strapped to a newborn chest by the mother with minimum training and enables the mother to detect whether a child is experiencing a distress and automatically call a health worker to understand whether she needs to seek care. So with the lack of maybe too much time, I don't want to deprive my colleagues from their allocated time, and I'm looking forward to hearing from them as well. But we are living in a very exciting time right now where the evidence base is growing, where the availability and accessibility of technology is getting greater and greater. And the onus is on us as public health professionals to think about ways in which technology, digital health, and mHealth can help us connect the actors of a health system. It can help us collect better data so we understand who is experiencing the worst outcomes so that we can target resources to those individuals, and to, most importantly, compress the time between our identification of a problem and the response to that problem. And with that, I want to thank you all, and I would be happy to answer questions at the end of this session, or to get emails or tweets from any one of you about your questions about our work. With that, thank you very much, and let me hand it back to Dr. Otero.
Thank you very much, Alain. It was a great presentation. And now I would like to ask Dr. Pablo Duran to share his screen. And as a reminder, remember that we can have all the questions in the Q&A section and will be answered after we finish the session. Pablo, please go ahead.
Thank you. Thank you very much, Dr. Otero, and good afternoon, good evening to everyone. I want to thank the organizers and authorities of the meeting and of these panels, along with the colleagues sharing this session and the audience for your attention. I'm really happy for sharing this session, and I'm sure that we will have many common ideas on this interesting topic. On behalf of the Pan American Health Organization and the World Health Organization, and on my own, from my perspective, I'm happy to share in this session. And I would like to start highlighting the main situations related to perinatal health. Some of them are in common for what Professor Labrick has presented. We know that in the Americas, one of the main challenges is that related to the burden of mortality, both in perinatal mortality and in neonatal mortality. And this burden accounts for around 1 per 100 live births. And related to that, the second challenge is even when along the last decades, the neonatal mortality has been going down, there still exists a huge gap in terms of perinatal mortality within the region between countries. And that makes that, as you can see on the figure on the right, that as also Professor Labrick mentioned, the burden of mortality during the first day and first week of life, it's almost the same risk as it can be seen during or from the 5th decade of life. So it is really important, but not only important due to the burden of mortality, but also due to the burden of disease. Adverse neonatal conditions and birth defects are among the leading preventable causes that contribute to the burden of disease and disability. And they account, neonatal and perinatal conditions and birth defects, for more than 15 million disability adjusted years in the region of the Americas. We have the problem here, we have the challenge, but we have also the evidence to respond to these situations. And in terms of these main causes that are related to neonatal mortality and morbidity, which are prematurity, sepsis, asphyxia, along with birth defects, they can be reduced. And this is an analysis that we estimated in the Americas region that by 2030, it can be reduced, these main conditions, prematurity, sepsis, and due to asphyxia, in more than 45,000 deaths if specific interventions are implemented. So we have also the evidence, and we have the frameworks that guide about promoting quality of care and which allows achieving expected results through these two main pillars, which are the provision of care, evidence-based interventions, and also promoting the experience of care, contributing to families and parents to be active participants in the care. But we know that the pandemic has came and it affected the situation, and disruptions have been reported in more than 40% of health systems worldwide and in the Americas. And this has been, the impact has been more important in terms of sexual and reproductive health, maternal and neonatal health. So the limitations to circulation, the socioeconomic conditions and impact of the pandemic, and the restriction of resources had contributed on this situation. So the situation that I briefly highlighted, it exposed that at this time that we know that communication and technology is one of the main characteristics of this time, and we know as a knowledge society. From WHO and from PAHO, and as part of our mandate, is to highlight the importance of e-health and the safe and cost-effective use of information and communication technologies. So achieving cost-effective and safe results is therefore central for us and promoting the implementation, the policy, education, training, using electronic medical records in order to improve the quality of care. And just some examples, the virtual campus of public health from PAHO offers e-learning training materials with different modalities. And the example, for example, from Uruguay in terms of interoperability between the perinatal information system and the birth certificates, which are linked together in order to provide information from the clinical record to the statistic system, are one example. But based on this context, and we said, or we identified the need of strengthening this aspect and focusing on newborn health. So we carried out in 2019 this rapid systematic review along with colleagues from Hospital Italiano de Buenos Aires, with Dr. Otero and other colleagues. And this review of the evidence regarding availability, characteristics, and mainly focusing on the results of information and communication technologies, but applied specifically on perinatal health. And we conducted this systematic review following standard protocols and taking into consideration the mesh terms as you can see there: health informatics, telemedicine, mHealth, newborn care, and neonatal care. From a total of 305 papers after reviewing the legibility and review process, 10 papers were selected. 3 were related to telehealth, 7 related to mHealth, and 1 related to e-learning. We try to identify, I'm going to reinforce the idea, the evaluation, the assessment of use and results. All the studies except 1 were randomized controlled trials, and the target population were either healthcare providers or parents. And the studies I'm at assessing the impact of diagnosis, provision of healthcare, training, promoting adherence to interventions in parents, or improving the quality of care. Regarding telehealth, one of the papers identified was oriented to assess the validity of telemedicine for the evaluation of acute phase of retinopathy of prematurity. Another one assessed the impact of a telemedicine system with automatic reminders on outcomes directed to the woman with gestational diabetes. And the third one oriented to assess the efficacy of a video conferencing intervention compared with standard postnatal care at primary healthcare centers. In the first case, positive results were reported with high sensitivity and specificity, with relative good, negative and positive predictive variables value regarding the use of telemedicine in order to diagnosing and assessing retinopathy of prematurity. Regarding improving quality of care in gestational diabetes and perinatal outcomes, the authors in this case reported no significant differences between the two groups in regard of maternal blood glucose or infant birth weight, but they reported increased contact between the woman and the healthcare providers. And finally, the third one, using telemedicine in postnatal care in women showed an increase in the number of intervention in the intervention group in terms of control, but with fewer visits to the healthcare center. So improve the accessibility to care, but did not imply in accessing the health system. Regarding mHealth, we identified 6 papers. 2 of them aimed at assessing the impact of text messaging in terms of reminding parents for vaccinating their infants, and 1 assessed the effect of nursing quality improvement and mobile health interventions in order to improve newborn sleep practices and breastfeeding. And the results in general were positive, even when there were not consistent the two papers assessing the effectivity of text messaging in order to improve vaccination. But all the 2 studies reported high adherence to vaccination. And the third paper promoting sleep quality and breastfeeding showed significant results in the two groups. Another set of papers aimed at assessing the adherence and improvements in the quality of care for neonatal resuscitation and quality of care at delivery. These papers show excellent results when assessing the acquisition of knowledge, skills, and reducing perinatal mortality after the intervention. And regarding e-learning, the e-learning component, the study that we could identify involved assessing the difference between teleeducation or classroom training in terms of improving skills and knowledge on neonatal resuscitation. And again, the post-training results show statistically significant increase in the skills and practice of the healthcare providers. So this review and analysis have allowed us to recognize that in terms of telemedicine, the studies have shown improvement in diagnosis or clinical care. In terms of telemedicine, when it was applied for diagnosis or prenatal and postnatal care, the results support the importance of improving and expanding the use and promoting the implementation in terms of facilitating accessibility to healthcare and contributing to achieving results. In relation to mHealth, the results were, even when they were not absolutely consistent regarding, as I said, the adherence to immunization schedules, this may be due to the fact of immunization in children is somewhat maybe recognized by families and care providers as an important intervention, and they can sustain, but still we were able to identify positive results in relation to parenteral adherence to safe sleep and breastfeeding. So this intervention show important results, and the paper on e-learning also have shown important results in terms of implementing, mainly when the distance and the availability of, or the possibility of in-person training is not possible. But at the same time, based on these results, we can highlight at first that they are not enough in terms of showing the impact and the potentiality of implementing e-health regarding perinatal health. I have shown the challenge of inequities in terms of results in terms of perinatal health. And again, we need to identify or highlight the inequities in terms of accessibility to information and communication technologies in the region, even when they have shown an increase. Still, we can see that in the Americas, for example, the difference between rural and urban population are high. So the main challenges for the region, as we've seen in all the presentation, may be highlighted as the limited access to health services due to different conditions, economic, cultural, geographical, or ethnic, the overlapping epidemiologic profiles, as we have seen, the burden of disease, the burden of mortality, the burden of disability, and the inequities between groups, the insufficient infrastructure, human and budgetary resources, but at the same time, the high potentiality of information and communication technologies to reduce this gap. The directing council from the Pan American Health Organization has approved last week the roadmap for the digital transformation of health sector in the Americas. And the document urges the member state for considering their own context and priorities to strengthen institutional and community capacity at all levels to implement digital health solutions, helping to support the accessibility and the quality of care in general, and I'd like to add, and for the perinatal health, and to increase and promote and to support the participation of indigenous population and other ethnic groups in this process. So even when the evidence shows that we need to strengthen and to expand the assessment of evidence on cost effectiveness of using information and communication technologies, we are sure that the implementation will contribute on improving the results in the population. So thank you very much, and I keep open to questions and comments. Thank you.
Thank you very much, Pablo, for your presentation. Now it's Douglas' turn. So Douglas, I ask you that you turn on your video and share your screen. Just a reminder, we will have the Q&A sessions after we finish this last presentation. So you can use the Q&A section to pose your questions.
Hi, can you hear me?
Yes, we can hear you.
Okay. Thank you, Paola, for giving me the floor. And good afternoon or good evening to everyone. I would like to, first of all, thank the organizers for giving me the opportunity to give my perspective about mHealth in maternal and child health. My name is Pamasom Douglas. I'm the founder of Public Health Innovations, which is an organization, a non-profit organization based in Cameroon and providing innovative health solutions. Despite the effort made for attaining the Sustainable Development Goals 4 and 5, reducing high maternal and child mortality remains a challenge for most developing countries, including Cameroon. mHealth can be defined as the medical and public health practice by mobile devices, such as mobile phones, patient monitoring devices, personal assistants, and other wireless devices offers opportunities for improvement of health outcomes and healthcare services delivery, particularly for maternal and child health in many countries around the world and regions around the world. In Cameroon, Central Africa, the use of mHealth for maternal and child health programs is not widespread, but when well examined, the few initiatives launched and implemented in the area have proven to bring a big difference in the maternal and child health outcomes. Cameroon still has a relatively high maternal mortality rate of 596 per 100,000 live births. Approximately 40% of births are unattended by skilled healthcare workers with high out-of-pocket expenditures, poor resources allocation, poor functioning referral systems, long trekking distances to health facilities, all of this leading to low rates of use of maternal health services. The level of mobile phone ownership by the Cameroon population exploded in the past 10 years, and the rate of usage of this mode of communication in the population rose from 9.8% to 71% between 2004 and the first quarter of 2014. Today, Cameroon has officially more than 17 million subscribers to mobile phone in a population of 24.5 million people. This high rate of mobile phone utilization offers wide opportunity in improving, strengthening health system, thus improving healthcare service delivery and maternal health outcomes in particular through mHealth applications. Here is the overview of maternal and child health in Cameroon. In 2011, Cameroon had a maternal mortality ratio of 782 per 100,000 live births, as compared to 669 per 100,000 live births in 2004 and 454 per 100,000 live births in 1998. Cameroon did not meet MDG5 target of reducing maternal mortality by 75% in 2015. In order to get on track, maternal mortality in Cameroon needs to fall at least below 140 per 100,000 live births. To achieve this target, the country has started to focus on interventions like family planning, infection control, increased training of health professionals, and financial support for these programs. According to the 2018 Cameroon Demographic and Health Survey, the infant mortality rate in Cameroon is 48 deaths per 1,000 live births. Most infant deaths occur during the first month of life, where the neonatal mortality rate is 28 deaths per 1,000 live births. The under 5 mortality rate is 80 deaths per 1,000 live births. This means that 1 in every 12 children dies before his or her birthday. Under 5 mortality increased in Cameroon between 1991 and 1998, but has been declining steadily since 2004. The main causes of this high death rate remain prematurity, birth asphyxia, and birth trauma, as well as sepsis. This is also accentuated by factors such as poverty, poor living environment, and low level of education. And now, what is the current situation of mHealth in Cameroon? According to Digital Reporter, the number of mobile devices, connections, and utilization in Cameroon increased by 19% in 2020, being equivalent to 90% of the total population. This progress continued with an 11% increase in 2021, making up almost 99% of the total population. Several studies have proven the effectiveness of the mobile technologies in the amelioration of mother and child health care through its use in the amelioration of antenatal care uptake in health facilities in Cameroon. In 2020, the global health situation in many regions of the country was assessed using mobile health, and the result proved that this is a simple and useful way to collect information about health facilities and the health situation in the regions compared to the traditional methods. 4 main applications of mHealth have been observed to be the most utilized in the Cameroon healthcare environment. These are education and prevention, data collection, healthcare worker communication, as well as e-health. These solutions were consistently applied in many research and implementation health projects across the country. An example of how education and prevention is used to improve maternal and child health can be shown in a study conducted by Suzanne Sapp in 2019, where she used WhatsApp platform to provide education to expecting mothers. After 2 months, the results showed an increase of knowledge on ANC in the intervention group compared to the control group. There was also an increase in the number of participants who attended ANC and a decrease in the complications among women in the intervention group compared to the control group, as shown in the diagram. An example of data collection was presented in another study realized in 2020 to compare a smartphone-based system with the former paper-based system for data collection in many health facilities. The result obtained showed a high level of completeness, promptness, and quality for data collected using the smartphone-based system compared to the former paper-based system. This can be observed in the diagram. Another application of mHealth for maternal and child health in Cameroon is communication among healthcare workers. This was demonstrated by the WHO Global Observatory for eHealth in a survey conducted in its member states in 2016, where 70% of countries surveyed, including Cameroon, reported on the use of mobile health devices for consultation between healthcare professionals. A study conducted by Boschri also revealed that community health workers' interaction using a mobile health platform increased their coverage in home visits for pregnant women in the populated northern parts of Cameroon. The practice of e-health for maternal and child health intervention in Cameroon was described by Matko et al. In 2016 during a pilot study that used an integrated technology platform, including a mobile app, wireless weight scale, and blood pressure curve, leading to the reduction in ANC visits. There was also an increase in satisfaction and patient engagement with no change in perinatal outcomes despite the decrease in face-to-face contact. Now, there are many challenges that prevent the implementation of these mobile health strategies for maternal and child health in Cameroon. They can be classified into 2 main categories, which are technical challenges, where we have usability, interoperability, reliability, data security and privacy, as well as network access. We also have socio-economic challenges, such as user literacy, where we have healthcare workers and patients with very low level of literacy related to mobile health technologies. We also have mobile device availability as a challenge, as well as acceptability. Mobile health technology has proven to be an effective tool to improve health outcomes, including maternal and child health, as well as strengthening health systems in most developing countries like Cameroon. Several applications of mHealth have been identified by different authors around the world, with mainly 4 of them being used for maternal and child health programs in Cameroon. These are education and prevention, data collection, healthcare workers communication, as well as e-health. Their utilization has shown satisfactory results in the different programs they have been applied, despite some challenges. However, the use of mobile health technology for maternal and child health programs is still lagging behind in the Cameroon health system. Hence, the need for health authorities to fully integrate it in the healthcare system. Thank you for your kind attention.
Thank you, Douglas, for your presentation. Now I will ask you, there you go. So now I will ask the 3 panelists if they can turn the cameras on and we can go through the Q&A part. I would like, first I see then some of the questions were answered on the section, but I guess that we can maybe go deep in some of the questions. One of the first things that come up is that although the situation in Bangladesh, in Latin America, and in Cameroon, as an example, the challenges were quite similar. And the results of implementing mHealth were also quite similar. So the first I would like to ask the three of you is, what is still missing? Because we know that this works. We know that that there's a need for mHealth, and on the other hand, right now the penetration of mobile technology worldwide is very high, over 70%, even in the countries with the lowest with the highest economic burden. So I will ask first Alan, and then Pablo, and later Douglas, in order to observe. Do you think that the government should be more involved? Do you think it's far from the organizations? What is missing to make that final step in order to mHealth to flourish?
Thanks, Paula. I think the answer is it's happening. I think we are seeing before the pandemic, and I think now the pandemic to some extent has accelerated the investments that countries have made in digital innovations to coordinate, track, and manage the COVID-19 either resource allocations or case tracking and tracing. So I think we will see coming out of 2021 and going into 2022 a lot more enterprise, national level digital health systems. There has been a lot of conversations happening at the global level about enterprise architecture and the need for investments, which donors have not made until very recently, into the kind of capacity, both technical and human resource capacity, that needs to exist for digital health to flourish, right? So we're talking about standards, country level legal and ethical frameworks, country interoperability paradigms that implementers can adopt and use in order for their technologies to scale and talk to each other. So while the presentations were going, I put a number of links in the chat. One of these is the Digital Health Index. That is an effort by a global consortium to develop metrics to measure country maturity technological maturity in terms of the necessary building blocks that WHO and ITU have defined as the enabling environment for digital health to flourish. And we're seeing that around the globe, these metrics are improving. But I think the bottom line is we need more investments in the ecosystem, in the enabling architecture. We need to stop sort of investing continuously in the perennial pilots that emerge. We've learned a lot, and we do need to double down on investments of some of these technologies at scale. So we're seeing this happen, and I'm very optimistic because things are very different today than they were a decade ago. And we're seeing country level programs that are at scale in South Africa, in India, in some parts of Latin America, and across Southeast Asia, right? In China, in Cambodia, Vietnam, systems that are really achieving in Kenya, national scale immunization tracking systems that are now deployed and being increasingly adopted. And so I'm not so pessimistic that we're not seeing change. I'm actually very hopeful that we are seeing enterprise grade architecture being put down, and more of these systems, and in the next 5 years will be more and more apparent. The health systems are like elephants, right? It takes a lot of hands on the elephant to move the elephant from one place to the other place. Yeah. And we're disappointed, in 2 years, we don't see a massive movement of this elephant, but the first foot has moved forward, the second foot has moved forward, and before you know it, we'll see this elephant moving along the pace of technology that we see around the globe.
It's a good metaphor. Thank you, Ellen. Pablo, would you like to add something else to what Ellen said?
Yes, thank you. I agree with Alan. I am also optimistic, but I think I highlight three words related to your question. One is equity. I am sure that there are important availability of tools and mHealth approach, but if we don't have accessibility, and mainly to those who are at a higher risk or disadvantage, the impact will be not the best one. The second is focused interventions. We know that the accessibility is not the same for everyone, but for example, in distant areas or in different settings, working on specific interventions focused to field workers or some specific groups may have a great impact. And this brings me to the third word, which is the dialogue. I think that it does not rely only in one sector. It's not responsibility of the private sector, nor the public or the government. I think the dialogue between the academia, the private sector, those responsible for developing, and also the national government, national or subnational government, need to be involved, dialogue, and look for improving the content and improving the accessibility for making it with higher impact. Thank you.
I can just add one quick comment, Paula. You know, I think the other two things we've seen, there's hardly a country left that does not have a explicit digital health strategy. And that's a major path movement forward, where once a country has a strategy that is an explicitly defined pathway to the integration of digital health, once you know you have these resolutions that are passed by the World Health Assembly, people, you know, ministers start to pay attention, and we start to see ministries of health and donor agencies ask, well, why is there a resolution if this, you know, we're not serious about this? And so you start to see the first step, which is that plan, that vision. How do we as a government take notice of digital health solutions and begin to consider which ones make sense for our population, given what Pablo has well pointed out, the gaps in access and the important groups that may be left out of the digital health innovations. And so given all of that, right, the first step being a plan or a strategy, and that's already happening around the world, and communities of practice have cataloged these, and I'll put a link in the chat. But the second thing is the investment in global goods. And so there's another link I just placed in the chat called the Digital Square Investments in Global Goods, where large funding agencies and country governments have come together to identify technological building blocks. So think of it as Lego blocks that you can, once they are developed, we should not be reinventing the wheel again and again and again, but we should be able to use these building blocks that have been shown to be robust, open source, and accessible to people in any country to strengthen our health systems without having to reinvest heavily in these sort of core building blocks. And so that's happening as well. So these are signs of positive forward direction.
Yes, before I give the word to Douglas, what you were saying is true. In Latin America, Uruguay, that was one of the first countries to develop a national digital health strategy, has made a great deal of improvement and is an example for the rest of the countries in the region. So it's really good what you're saying. Douglas, would you like to add something else?
Yeah, thank you, Paola. Just to say that I completely agree with Dr. Allen that we have to be optimistic about the advancement on our mHealth strategies, because especially here in Africa, there are so many things, so many changes that are being observed. And I'll just add that it's just for, health authorities to adopt, to try to see how they can really invest more on the use of, because the results are clear that mHealth can really bring a big change in the health system. So it's just for health authorities, especially here in Africa, where we don't really see the will.
Well, while he gets back, I will.
So I just pasted in the link in response to Doug's question point.
Yes.
These are 42 African country government digital health strategies that were compiled last year by ICT Works that are available on the public domain. So to get a sense of, at each country level, how countries are looking at adoption. There's another instrument that the WHO released earlier this year, which is known as the Digital Implementation and Investment Guide, which I'm trying to find the link here, is a tool for ministries of health to work on identifying the key areas of importance. And as Pablo pointed out, what are the strategic domains where digital health investments can take the current state of the health system, not the digital health system, the health system. Yes. And what are the opportunities for digital interventions to address the current bottlenecks or pain points being felt by the health system, right? So if it's a challenge in supply chain management or a challenge in demand creation, the first step is really examining the and this is what informaticians do, right? We create complex flow diagrams, UML swim lane diagrams to describe how these systems work, digital or non-digital, and then look for those pain points to ask ourselves, and so one of the questions in the chat was about this, is a digital solution the best solution for this problem? Right? Because we don't want to be hammers looking for nails, right? We have to be problem focused and keep our eyes on why we are looking at digital health. Is it cheaper? Is it better? Is it faster? Is it more cost effective in this circumstance than an alternative might be? And if the answer to those questions is yes, then by all means we should be considering a digital intervention in this particular circumstance. And the goal is to go from the current state of non-digital interventions to a future state, which might include digital solutions.
So please, Paulo, go ahead, and then we give the word back to Douglas.
Yes, just one second. Alan mentioned if it's cheaper, easier, and regarding the last question on the Q&A, I think it's also complementary, because some investment need to be on the building capacity, infrastructure, roads, etc. And e-health does not replace the other interventions. So we need to, or countries need to sustain investment in both infrastructure and also technology and e-health. This is my question, my comment. Thank you.
All right. Douglas, do you want to continue with what you were saying?
Yes, sorry, I had an issue with my internet connection. Yes, as I was saying, I completely agree with what Dr. Allen said, that we have to be optimistic about the advancement that have been observed in this mHealth domain, and also, as I mentioned, in the main challenges that we have are also, especially here in Africa, there's a great lack of political will for health authorities to invest in these innovative strategies to improve to strengthen the health system. So countries need to, as I said, countries need to invest more on those strategies in order to sustain the.
Good. So I will, some of the questions that were, well, Alan, thank you for answering most of the questions directly, so it's really good. And I would like to address the question that Sabine has written. She says, to all three, how do you see differences between lower middle income countries to high income countries. Do lower and middle income countries prevent errors we did in other countries? Example, building without having a strategy, non-interoperable monolithic legacy systems, etc. Do you think that we learn from that, or we are making the same mistakes? I would add to Sabin's question.
Pablo, do you want to go first?
Yeah, I agree with Paula. I think these two are the possibilities. We learn and we make the same errors. I think it's also cultural related. So every situation, every country, every culture would address in a different way. But I absolutely am sure that most of the lessons that have been learned from past interventions will make countries, least and middle income countries, to make it better based on previous experiences.
I think, you know, we've learned a lot about how not to develop national or regional systems in the absence of standards. And I think that it actually is a question that was brought up by one of the last questions here by oh, I forget who asked this question, but I just answered
it. Was
Stefano Bonacina.
Yes.
So we are increasingly, so the last, I would say 3 years, we have seen an explosion in the adoption and versatility of HL7 FHIR standards that are accessible to both high income and low income contexts. The same sort of standards-based approach can be used for sophisticated health systems where, you know, the problems are not the same as in low income countries, but certainly the availability of these very flexible, very adaptable standards that can address both public health focused intervention strategies where you're looking at health systems that are really focused on basic coverage of immunization, looking at improving the coverage of antenatal care and postnatal care, sort of fundamental health system interventions that still have to reach adequate levels of coverage in some of these contexts. And so, you know, it's exciting that we do have standards that have emerged that allow us to build systems that will be interoperable. I think over the last decade, let me correct that, billions of dollars have been spent by investments in e-health and m-health solutions. They've always fallen short of being adequate to allow these systems to build for scale and for sustainability, right? So as Dr. Duran pointed out, you know, you'll often have an investment that is really focused on testing a pilot concept, but it's not building the ecosystem. It's not building human resource capacity for maintaining that system and growing the system. And so what we've learned from these mistakes is, you know, throwing money, small amounts of money continuously at a problem will not solve that problem. But there is an opportunity to not make the mistake of say, building 25 national electronic health record systems across different hospitals that don't talk to each other. Countries that don't have that legacy architecture can build systems from scratch with a vision, with a plan, with an interoperability framework in mind that prevents the kind of frustrating interoperability challenges we face in countries like the US. When my daughter went from one provider to another pediatrician, in 2021, I was faxing. Let me repeat that. I had to fax her health record from one provider to the other provider because there was no back-end digital interoperability. So thank goodness I had an old dusty fax machine I was able to dust off and plug back in and have not explode on my table. But you know, so certainly I hope that we won't have to go through these decades of legacy systems, and we can start with systems that do interoperate right at the very beginning.
Well, I recall there's a saying, I remember that Bill Hirsch told me once that standards are like toothbrushes. Everyone has one, but is not willing to use the one from the other person. So that is the problem. That's why there's a need to have, like you both said, a national digital health strategy, and that has to work on standards, and the standards have to be not only for the country, the region, but worldwide. I guess that all of us that have been involved in the development of health information systems, usually convincing people and convincing government officials that standards are needed is one of the greatest challenges.
So what drives this, Paula, is money, right?
Yeah.
When at the end of the day, you start to see it is important for us to be able to transfer patients from one population to another, as we see global migration continue to increase, and we see the borders between adjacent countries become more and more porous. The importance of being able to provide continuous care to patients across these borders becomes a driver for this cooperation. Can you imagine? It wasn't so long ago, right? It was a few decades ago that airplanes landing in different airports had to have adapters to fit the fuel tanks that were available on that landing strip. And shipping containers that were loaded onto ships were of different sizes and shapes. And then finally people said, this is absurd. We're losing money and we're losing efficiency by not having global standards. And so now even the standards that are being adopted are paying close attention to, even if there are a few majority standards, do these standards talk to each other, and do we have systems that allow the multiplexing of those standards? And I think you know, we will. I'm being optimistic. Things will get better and better as we go forward.
No, tomorrow we're having the WHO session, and I recall Marcelo Agostino is going to be there, and he says the banking system has resolved it. Because you said it's all about the money. With your debit card, you can extract money if you have funds from any bank in any place in the world. So if they can make it work, we should be able to make it work. So there was one question that Paulo addressed. It was, what is the relationship and how does one judge the relative importance of factors such as physical infrastructure like roads in providing access to health and availability of healthcare workers in comparison to mobile health in impacting good healthcare? Paulo addressed that, and I would like, if you, Alain, would like to add something else to that question.
So it's an excellent question. And, you know, I think I have colleagues in environmental health who say, you know, that we should invest in one thing, and that's building roads. And if you build roads, maternal mortality will come down, neonatal mortality will come down. And, you know, he has a point. And I think we need to look at the long-term vision and the short-term vision as well. Neonates and mothers to be and new mothers are still dying in countries around the world at a rate that is unacceptable. And so we need to ask ourselves, what tools and resources do we have at our disposal now that can be implemented with reasonable amounts of effort that can change the lives and improve the chances of better outcomes for people on the ground today? Building roads and improving water systems are expensive long-term infrastructural improvements that hopefully we will see happen globally. And you know, again, unfortunately, in maybe it's my old age cynicism, but you know, the money matters, and who's going to pay for these things? Where is that money going to come from? How do we justify building a clean water system that delivers water out to a remote farming community in Masai Mara or in the middle of a desert community in Sudan, right? So if those are not possible, what can we do to improve access to information, to strengthen the community health providers? And the answer might be a digital health solution makes sense in those kinds of circumstances. But you know, I've seen enough newborns die and mothers die needlessly to stand by and say, I'm going to wait until a road is built in order for this situation to get better. So I think we're all impatient optimists. We want change to happen soon, but we want to make these changes based on smart decisions, which is why it's taken 10 years to go from the idea of digital health to now the implementation of digital health.
All right. So I guess we are running out of time, and I see no further questions in the chat room and even in the Q&A section. So I just want to thank the three of you. It was a pleasure to have the three of you in this session, and how you addressed all the different issues regarding health and the road ahead. So if you want to give some kind of closing remarks, please, Alain, Pablo, and then Douglas, please leave us your farewell message.
No, I just want to extend my thanks to you and to MedInfo for hosting us. And as the sun is setting, it's casting this ominous glow on my face like I'm some kind of evil scientist, but my intentions are absolutely good. It's been a pleasure to be part of this very great panel, and your questions from the audience have been fantastic. I think let's continue to be impatient optimists. Let's look at the data, let's examine the evidence, let's make noise for better evidence and stronger research. As we ask the questions of, you know, what interventions should we be investing in? Why should we make that argument? And is this better than the alternative non-digital solution? But I think, you know, I'm hopeful that the next 10 years will be transformative.
Thank you, Len. Pablo?
Thank you. I also want to thank for the invitation, for the colleagues' presentations, the discussions. And my last words are also optimistic. And I'm sure that if we continue trying to strengthen the dialogue between the epidemiology, the public health situation, and the results from technology, and trying to base our decisions, both from the public health, perinatology, etc., and from the technology, based on evidence, we will make big improvements. So my invitation is to not only to continue developing and implementing, but also evaluating the impact and thinking on equity and trying to find the best intervention for the person that needs to receive this intervention. So tailoring the interventions and tailoring the use of technology in order to improving health of mothers and newborns. Thank you.
Thank you, Pablo. Douglas is having some kind of a problem with his internet connection, so I guess that he thanked us through the chat room. And by this, I just, once again, in my name and under Philip, Sabine, Elaine, and Najib, really want to thank you because it was a great session. And for the rest, remember that tomorrow, as Elaine has put in the chat, tomorrow at 2 p.m. UTC, we will have in the next session. So I hope we can see you all tomorrow. Enjoy the rest of your evening, your night, or whatever time zone you are. Bye-bye.